Finals SAQ16, Aortic Stenosis. The case: a 70-year-old woman with aortic stenosis presents for an open aortic valve replacement. A. What is the pathophysiology of worsening aortic stenosis? This includes the latent phase, compensatory phase, decompensation, and symptomatic phase. During the latent phase, left ventricular outflow obstruction occurs due to abnormal valve. Causes of aortic stenosis includes rheumatic fever, congenital bicuspid valve, and age-related calcification. Compensatory phase: left ventricle hypertrophies to overcome outflow obstruction, maintaining ejection fraction. Consequent increased oxygen demand but poorer oxygen supply and diastolic dysfunction occurs. Decompensation phase: subendocardial ischemia occurs due to reduced oxygen delivery to the hypertrophied myocardium. Increased LV-EDV and LV-EDP results in increased pulmonary capillary pressure with pulmonary edema and mitral regurgitation. Ejection fraction reduces as hypertrophy increases in the face of worsening outflow obstruction. During the symptomatic phase, as blood passes through the narrowed valve, it accelerates, gaining kinetic energy. By law of conservation of energy, it therefore loses pressure, leading to reduced perfusion pressure of coronary arteries and thus reduced oxygen delivery to the already compromised myocardium. Consequences include angina, breathlessness, syncope, and sudden death. B. Which specific cardiac investigations may be used in assessing the severity of aortic stenosis? Investigations include echocardiography, left heart catheter study, MRI, and ECG. Echocardiography may be transesophageal or transthoracic. Assess the valve via Doppler assessment of peak flow velocity, mean pressure gradient, effective orifice area, and presence of regurgitation. Assess the consequences of valve stenosis via left ventricular dimensions and function, mitral valve competence, left atrium, pulmonary artery pressure, right ventricular function, and post-stenotic ascending aortic dilatation. Left heart catheter study involves retrograde catheterization of the aortic valve to assess pressure gradient. MRI is used to assess the consequences of aortic stenosis. ECG demonstrates the consequences of aortic stenosis, such as left ventricular hypertrophy, ischemia, and arrhythmias. C. Give values for the peak aortic flow velocity, mean pressure gradient, and valve area that would indicate that this woman has severe aortic stenosis. Features of severe aortic stenosis includes peak aortic flow velocity of more than 4 meters per second, mean pressure gradient of more than 40 millimeters mercury, and aortic valve area of less than 1 cm squared. D. What would be your haemodynamic goals for the perioperative management of this patient? Maintenance of myocardial delivery of oxygen with adequate systolic and diastolic blood pressure within 20% of normal values, as monitored by invasive blood pressure monitoring. Maintenance of cardiac contractility via balanced anesthetic technique. Adequate filling as guided by cardiac output monitoring. Inotropic support if left ventricle is poorly functioning. Optimization of preload with adequate filling guided by cardiac output monitoring. Maintenance of sinus rhythm at the rate of 60 to 80 beats per minute. Monitoring with 5-lead ECG. Avoidance of tachycardia. Good management of pain. Considering use of beta blockers. And possible need for pacing post-bypass due to surgical interruption of conduction pathway. Maintenance of afterload. Coronary artery filling is dependent on aortic root pressure. Avoidance of excessive doses of IV induction agents or inhalational agents maintains afterload. There may be need for alpha agonist as guided by cardiac output monitoring.